Good afternoon, guys. Today we'll be talking about the evaluation of supracondylar fractures when they present to the casualty, and also briefly we'll touch on the Gartland classification of supracondylar fractures. So, supracondylar fractures, as you know, are the most common elbow fractures, accounting for about 60% of the cases of pediatric elbow fractures. They have an associated vascular injury in about 10% of cases and an associated nerve injury in about 5 to 20%. It's a broad range, yes. And also more commonly in around 5 to 8 years of age. So the two most common mechanisms of injury are in the fall on the outstretched hand with elbow hyperextended and pronated or supinated, but usually pronated. As you can see with the elbow hyperextended, if there is a fracture in the supracondylar area, it will lead to an extension type of fracture, which I'll be showing you what it is. And also another mechanism of injury is direct fall on the elbow. And if the student or the kid directly falls on the elbow, it will lead to a flexion type of fracture. These are the two mechanisms of injury, push and direct impact or fall on elbow. Coming to the second slide. So this is very briefly the Gartland classification. Just for completeness, I'm just going to tell you what the classification is. And this table is a mix of many tables from sources, and I'll tell you what I mean by that. So type 1 is an undisplaced fracture or less than 2 mm displacement, and the X-ray of fat pad sign will be visible. In type 2A, it's a partially displaced fracture with an intact posterior cortex. The anterior cortex is ruptured, however, the posterior cortex is intact and it is hinged in extension. And there will only be sagittal displacement of the fracture. You can see here in this image, you can see the posterior cortex is intact and the distal fragment is going into extension, hinged in extension. And there's only sagittal displacement, which means on the lateral view, it will only be extended or flexed. Only one of the two. Sorry, this is the humerus. This will be extended and this will be flexed. Okay. And type 2B is the same as 2A, but in addition to deformity in the sagittal plane, there will be a rotation or translation. And type 3. So in many textbooks, type 3 is only mentioned as a single thing, a single entity. What I mean by that is, it is complete displacement. So the anterior and posterior cortex are fractured and there's no continuity between the distal and proximal fragments as visible on the X-ray. And some textbooks classify 3 as 3A and 3B. 3A is complete displacement with the distal fragment being displaced posteromedially. Type 3B is complete displacement with the distal fragment being displaced posterolaterally. And the other type is the flexion type, where it does fall under 3 in some sources, but here I put it in others, where the distal fragment displaces anterior relative to the proximal fragment. And type flow is a recent addition which was added by Leist et al., where he showed there's complete displacement with multi-directional instability, whereas there is circumferential disruption of the periosteal hinge. So how do you differentiate between type 3 and 4? That question might come. Makes sense. Type 3, what happens when we reduce a supracondylar fracture? First we give traction, and when we give traction, the coronal plane deformity usually corrects itself. And then in order to correct the extension, we flex the elbow. So what happens in that usually reduces an extension type fracture. But what happens in a type 4 is, whether you flex the elbow or extend the elbow in an attempt to reduce, there will be instability. So even if you flex the elbow in order to reduce it, the fragment will go into extension. And if you extend the elbow, the fragment will go into flexion. So that's what I mean by this type 4, complete displacement with multi-directional instability. And others, there's another subtype with medial comminution, and I've added the flexion type, which also falls under type 3, by the way, because it's completely displaced. So just for completeness sake, I've added a few X's. So this, what you classify this X-ray under. If you said type 2, you are correct, and it's type 2A because you can see this is a true lateral view and it doesn't look like there's any rotational component as visible here. Yes, you need the anterior AP view also to say this, but more or less. So there's disruption of the anterior cortex, but posterior cortex is intact, and as you can see, it's an extension. How would you classify this? Please pause the video. I'll continue. So what happened? As you can see here, the distal fragment along with the radius and ulna look like they're displacing towards the radius, which is laterally, and the proximal fragment looks like it's displacing medially. So the distal fragment is displacing laterally, and if you see the lateral view, you can see it's going posteriorly, the distal fragment. So posterolateral. So it comes under type 3B. Type 3B is posterolateral. So coming to the neurological examination when they present to the casualty, this is probably the most important along with your vascular examination. So in a child, they'll be apprehensive, they'll be in a lot of pain, they'll be anxious. So you try to play rock, paper, scissors with them in order to diagnose the neurological injury. So rock, paper, scissors. The rock is used to test the median nerve because most of the muscles of the flexor compartment, most of the strong flexors are supplied by the median nerve. So the rock is used to test the median nerve. Paper you can see is used to test wrist extension and extension of the fingers, which as you know, the extensor compartment is primarily supplied by the radial nerve. Thirdly, scissors or the peace sign used to test the ulnar nerve because the finger abductors and adductors, which are the intraossei, are all supplied by the ulnar nerve. Pin, posterior interosseous nerve, is tested by asking the patient to do a thumbs up, or basically thumb extension. Thumb extension, which is done by the extensor pollicis longus, is supplied by the posterior interosseous nerve. And finally, the OK sign, where the tips of the index and the thumb are touching. This is a good OK sign. As you can see, an O is formed. This is a false OK sign, and this is not how an OK sign should look like if the anterior interosseous nerve is intact or functioning. I'll show you again in the next slide. Here you can see this is a good OK sign, this is a false OK sign. The tips of the two fingers should be touching because the flexor digitorum profundus, FDP, is a DIP joint flexor, and the flexor pollicis longus of the thumb, both are supplied by the anterior interosseous nerve. So if that is intact and functioning well, the patient should be able to make a perfect O, not like this, not an oval here. This is a false OK sign. Next, most importantly, is pulsations. We should be palpating both the radial artery and the ulnar artery pulsations, and more importantly, comparing them to the contralateral limb or the normal limb. So the radial artery pulsation, everyone knows how to palpate. Ulnar artery pulsations, usually we don't palpate so much, but in how to palpate it. So we ask the patient to flex the wrist and ulnar deviate, and we check for the FCU tendon. So when you flex the wrist and ulnar deviate, the flexor carpi ulnaris tendon becomes prominent. Here I can feel it, and then just lateral to that, below the wrist crease, you palpate. You'll be able to palpate the ulnar artery around this region. You have to press a little bit, and you'll be able to feel the ulnar artery. And if the ulnar artery and radial artery of both sides are comparable, and the fingers are nice and pink, that's lovely, and it's very nice. And nice is not a mnemonic for anything, it's just nice. But if either one of the pulses are absent or feeble compared to the opposite side, however, the CRT, the capillary refill time, is less than 3 seconds and the fingers are nice and pink, it means the collaterals are working well. Suppose the patient comes to you at around 3 am, he can be taken up as an elective procedure as the first case at 8 or 9 am in the morning. However, if none of the pulses are palpable and the skin is looking pale, and this is bad, and an emergency exploration should be done almost immediately, and the patient should be taken up without waiting. So, as I was telling you about an extension type and a flexion type of fracture. So, in an extension type or 3A, there is posteromedial displacement of the distal fragment. Posteromedial. So, we know that the radial nerve runs just medial to the humerus shaft, and then in the spiral groove it crosses from medial to lateral, and it runs anteriorly. So it was a posterior structure in the posterior compartment initially. As it exits the spiral groove, it pierces the intermuscular septum and comes anteriorly and runs on the anterior aspect of the lateral condyle of the humerus. Okay. So in a posteromedial type of extension fracture, what happens is the distal fragment will be posteromedially displaced. However, the proximal fragment will be anterolaterally displaced. So it's the polar opposite. If the distal fragment is posteromedially displaced, the proximal fragment will be anterolaterally displaced. And as you can see, if the proximal humerus shaft and sharp spikes comes anterolaterally, lateral and anteriorly, it will compress and impinge on the radial nerve. So there will be radial nerve injury in a 3A extension type Gartland classification. And so the paper sign and the thumbs up sign will be absent, but the patient will be able to make a rock, do the scissor sign and the OK sign. Okay. In a 3B extension type, there will be complete displacement, and the distal fragment will be displaced posterolaterally, which will, so by the same previous logic as I gave in the previous example, if the distal fragment is going posterolaterally, the proximal fragment will go anteromedially. And we know the median nerve runs with the brachial artery on the medial side of the humerus, and it comes anteriorly over the majority of the anterior part of the humerus. Even distally, it's more anteriorly over the humerus, slightly more towards the medial side. And so if the spike of the proximal fragment goes anteromedially opposite to the distal fragment, it can damage the brachial artery and also the median nerve. And since the median nerve is a more superficial structure, the anterior interosseous nerve tends to take the brunt of the injury as it is a deeper structure. So if the fragment goes and pushes the muscles and the soft tissue over the anterior aspect of the humerus, what happens is this goes and puts pressure on the brachial artery and the median nerve, but those are little more superficial. So the deeper structure, which is the anterior interosseous nerve, gets caught in the mix, and this is the most commonly injured nerve in a supracondylar fracture of the humerus, the anterior interosseous nerve. So the patient will not be able to make a rock, and he'll not be able to make an OK sign. So if the patient, but he'll be able to make a paper, scissors and a thumbs up because the radial nerve, ulnar nerve and the posterior interosseous nerve are intact. I'll show you with the help of a diagram. Yeah, so you can see here, if it displaces anteromedially, the brachial artery gets impinged and the median nerve gets impinged. You can see even the anterior interosseous nerve is here, and this is a good diagram which shows us how the injury occurs. And finally, in a flexion type injury, where you can see the distal fragment is displaced anteriorly and the proximal fragment is displaced posteriorly, more so posteromedially because the ulnar nerve runs under the medial epicondyle. You can see it could impinge and damage the ulnar nerve. So flexion type fracture leads to an ulnar nerve injury, and you can see the patient will not be able to do the peace sign, or he'll not be able to abduct and adduct the fingers doing the scissor, whereas every other thing will be intact. Why I've put a tick and an X on radial nerve papers, because paper is usually done like this. When you play rock, paper, scissors, we usually do it like this, whereas the patient will only do it like this. He'll not be able to abduct the fingers because the ulnar nerve is damaged. Also, one last point to mention is that The reason I mentioned all the motor examination first is because sensory examination a child is rather difficult and they'll be uncooperative. So asking them if there's a decreased sensation here, here, and here is kind of, it's not possible. But anyways, for completion's sake, the autonomous zone for the radial nerve will be the dorsal aspect of the first web space. Median nerve will be tip of the index finger, and the ulnar nerve will be tip and the ulnar border of the little finger. So yeah, that should complete the entire neurological and vascular examination of a supracondylar injury.